this is an interesting case of what appears to be an iris coloboma with an advanced, mature, sticky cataract. But after detailed examination and history taking, the patient explained that as a child he had sustained an ocular trauma of a penetrating nature. So what we have here is not an iris coloboma, as evidenced by the presence of the zonules and the scar at the perilimbal area inferiorly. So this is actually a penetrating trauma with iris incarceration, which was treated many, many years ago. The patient also had an advanced cataract, a nuclear 3 to 4 approximately, which seemed a little bit brown and a little bit sticky, as will be shown in the video. So I started by putting some adrenaline into the anterior chamber to dilate the pupil as much as possible. But as you can see, the dilatation was insufficient. So I decided to put just 2 iris hooks, iris retractors, which gave me enough dilatation for me to proceed with my phaco. Phaco was routine. I usually do a phaco quick chop in these harder cataracts. As you can see, with the difficulty in the separation and cracking or the chopping of the nucleus, this nucleus was quite significant. So the plan for this patient was to remove the cataract and implant a monofocal IOL into the bag, followed by a 4-pass iris suture inferiorly to bring the inferior iris down and create or refashion the pupil into a more anatomical appearance to decrease any glare or visual phenomena the patient might be complaining of after the surgery. So phaco was completed uneventfully. The IOL was implanted and the iris hooks were removed. And then I proceed by injecting myocol into the eye to bring the pupil down, to see or to assess how much or how many sutures or what exactly I need to do in order to fix this iris incarcerated into that old fibrotic wound. A trick to see if you'll be able to pull the iris together and actually succeed with your suture is to test for iris elasticity, as I will demonstrate now, by getting an anterior chamber or a vitreoretinal forceps and to pull on the edges of the iris that you are planning on suturing and to see how much elasticity you've got and to visually assess if you'll be able to bring these ends together with a suture, or will the suture cheese wire through the edge of the iris, or even worse, cause an iris or an iridodialysis, which is rare but is gruesome when it happens. So my assessment was that we have enough tissue and the tissue was elastic enough for us to proceed with the 4-pass technique. I passed my 10-0 nylon suture through the limbus, and then I tried to clip the iris on the opposite sides and on the proximal side as close as possible to the margin of the pupil. You have to be careful when using these straight needles. They are tricky, as sometimes they would bend and they can whiplash and cause injury to intraocular structures if you don't pull them properly through their track. Another trick is to bend the needle maybe a quarter of the way from its ends to make its manipulation a little bit easier. So here we pass the suture to the iris. As you see, I'm having a little bit of difficulty because of these needles sometimes, like I said, could be a little bit difficult to maneuver inside the eye. But with persistence, I was able to pass the suture through the iris and through the perilimbal or the limbal area on the opposite side. You pull the suture out. And the reason why I passed through the limbus on the proximal side is because I had a side port already made for the cataract surgery. So I decided to pull, as well as I'll demonstrate now, both ends of the suture through my Phaco side port in order to complete or perform my suture. So I use again a serrated VR forceps. I grab the proximal end of the suture, pull it out of my MVR incision or my side port. And really, this 4-pass technique, which was first demonstrated by Dr. Ammar Agarwal from India, is a very neat technique that doesn't necessitate you having to go back and forth through the eye multiple times in order to secure your knot and have a good stable knot that won't break or won't go loose. So I go through my side port again and bring the opposite or the distal part of the suture to create a loop. Then I cut the proximal end of my suture as demonstrated, and then through my loop I will pass it 4 times, back and forth 4 times. So that's 1. Here's 2, and so on. And after the 4th knot, what you do is you grab the end, the free end, which you're passing through your loop, and the other distal end, which is out of the eye on the opposite side, and very simply you pull both ends to bring the suture knot to the center for it to slide on into the eye and to achieve proper opposition of the ends of your iris to recreate your pupil. In this case, the pupil is a little bit peaked, but I was satisfied with the results. So I decided to go on and cut the suture ends with the micro scissors, again a VR 23 gauge micro scissor. There are specific instruments for anterior segment suturing and such, but if you have VR equipment, they will suffice. That was the end of the case, and thank you very much for your time.